Hi, this is Dr. Janelle Heino. We're going to be looking at chest X-ray interpretation in the NICU. The first part is giving you some type of technique on how to read an X-ray, also looking at the anatomic structures in a chest X-ray, and then we're going to use those structures to give us a standard way to mark objects that we find on X-rays, such as ET tube placement or UVC and UAC placement. Part 2 is we're going to be looking at X-rays that show pathologic conditions, the most common ones we see in the NICU. So in order to do a chest X-ray evaluation, we need to have a technique, and we need to use that technique every time we look at a chest X-ray. The reason we do that is we want to get all the information that the chest X-ray can offer. If we're just getting a chest X-ray to look for an ET tube placement, and we only look at the ET tube, then we might miss other findings on the X-ray, such as the UVC has slipped out of correct placement, or the OG tube is in the incorrect place, or there might be a small pneumothorax. So when we look at an X-ray, we want to look at it in a systematic way. In order to do that, we need to understand what we're looking at. So just remember, a chest X-ray is a system of soft tissue surrounded by bony structures, which are the vertebral bodies and mostly the rib cage. Remember that on a chest X-ray, anything that's dark here is mostly air. Any type of gray or white substructures you see represent fluid, such as the pulmonary arteries or the pulmonary veins, the vasculature inside the lungs. The large structure in the middle is, of course, the heart. Vertebral bodies come down the center, and the 12 ribs come off each vertebral body. Up at the top, we see the clavicles, collarbones. So when we look at an X-ray, we can see how well inflated the baby is, how open are their lungs, and we can use the ribs to tell us the level of inflation. The dome structure at the bottom is the diaphragm. It separates the chest cavity from the abdominal cavity. So we can count down these ribs. Here's the first rib up here, 1, 2, 3, 4, 5, 6, 7, 8, 9. So we see that this diaphragm is at about 8.5 to 9 ribs. For a baby, that's perfect inflation. We'll be able to look at the tube and line locations. This baby only has an OG tube. You can see it coming down here, goes into the gastric bubble. Stomach is on the left, so it goes right into the stomach. This baby doesn't have an ET tube or any other lines. We're going to be looking for pneumothorax or other air collections. We're going to be looking for masses. Is there bowel in the chest? We're going to be looking at the heart size, the shape, the location. We're looking at the bones, the density of the bones, the size of the bones. Are there any fractures, any vertebral anomalies? And we're also going to be looking out here into the subcutaneous tissue. After you get good at looking at chest X-rays, you can basically go down that list pretty quickly, within just a few seconds. So keeping in mind what the lungs look like will help you interpret a chest X-ray. Here we see the trachea is coming down. It splits into the right side and the left side. The right bronchiole splits again into multiple smaller and smaller tubes, all the way out to the periphery of the lungs. Of note, the right side has 3 lobes. It has the right upper lobe, the right middle lobe. There's actually a much smaller right lower lobe. The left lung has 2 lobes, the left upper lobe and the left lower lobe. In reality, this right bronchus comes off a little higher than the left bronchus. It's why the ET tube will preferentially, if it's in too far, go down the right bronchus. We call it being right main stemmed. That's why it's very important for us on an X-ray to see this structure here, the first bifurcation of the trachea into the right and left bronchus. This area right here is called the carina. In reality, the structures are a little more complicated. So we see that the heart takes up a good deal of space in the middle of the chest. The right side of the heart is sending the pulmonary arteries out to the lungs. The pulmonary veins are returning back to the back of the heart. We see the aorta coming off here, going to the left side of the body. And we see that these lung structures, the blood vessels and the bronchioles, are bifurcating again and again, thousands of times, out to the periphery. They are all surrounded by these alveoli, also called the parenchyma of the lung. So we have lung tissue and all of these millions of blood vessels, as well as these millions of bronchioles. When we take off the front of the rib cage, we see that these lungs, that the lungs actually cover the majority of the heart. This is going to be important when we look at pathology of the lungs. When we peel back the lungs, we see that there are these two structures overlying the heart. It's important in full-term babies to know about these structures because this is the thymus, and it can be quite large and it can be seen on X-ray in bigger babies. For adults and premature babies, the thymus is much smaller. So when we look at an X-ray, just keep in mind, at the top of where the windpipe or the trachea starts is our larynx. It's where our ET tube enters into the trachea. The trachea comes down and then splits into the left and right bronchus. The right upper lobe is delineated by this horizontal fissure. It'll help us when we're looking at babies with TTN and pulmonary edema. Here we have the right middle lobe, and here we have that tiny right lower lobe. The left lung is just the left upper lobe and the left lower lobe. So when you look at an X-ray, you'll see all the bony structures, the ribs, the vertebral bodies, the clavicles up here. And you also have to remember that what you see in the middle of the chest is represented of these soft tissue structures. The heart in the center, surrounded by the right lobe, right upper lobe, right middle lobe, small area of the right lower lobe, and then the left lung over here. You can see that the lung that is overlying this heart is relatively clear because we get nice sharp borders of this heart structure. So now we can use the chest structures to determine where our ET tube, where our UB, where our UAC should be, and look for our OG-NG tube. The ET tube placement should be below the level of the clavicles and above the carina. The UVC placement should be around T8, thoracic vertebral body 8, about at the level of the diaphragm on the right side of the body. Remember, the right heart structure is on the right side of the body. The UAC placement should be between T6, thoracic vertebral body 6, and T9 on the left side of the body. The aorta comes off the left side of the heart and goes down the left side of the body. The OG and the NG tube should be into the gastric bubble or into the area of the gastric bubble on the left side of the body. So the optimal ET tube location is about mid-trachea. The carina, you can see it on X-ray. Sometimes hard to see, and sometimes it's easier to see if you step back a couple steps. The ET tube should be below the level of the clavicle and above the level of the carina. So one thing that we didn't point out before is that the vertebral bodies here in the very center are divided into groupings. Above where the first rib comes off are the cervical bodies. They're in the neck. The first rib is attached to thoracic vertebral body 1. Each rib, there's 12 ribs, so we have 12 thoracic vertebral bodies. We can use those ribs to count, to look at our inflation, to see where the UVC is, to see where the UAC is, and we can tell each other where those objects are based on where they're found by their rib count. So here's vertebral body 1, or T1. It's right here. Here's 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. 12 ribs, 12 vertebral bodies. The 11th and 12th ribs on a premature baby are frequently hard to find. They're smaller ribs. They don't go all the way around. These ribs start at the sternum and go all the way around the body and attach to the vertebral bodies in the back. But these ribs are called floating ribs, and they're only attached to the vertebral bodies. So here we see, once again, the OG goes down and it's sitting right in the middle of the gastric bubble. Perfect position. So let's look and see where the umbilical artery should be. Remember from our previous slide, the aorta comes off the heart, goes to the left side of the body. It splits into these iliac arteries. So when we place an umbilical arterial catheter into an umbilical artery, it comes down the umbilical artery, it enters down here into the internal iliac artery, feeds into the left internal, it feeds into the left iliac artery, goes into the descending aorta, and we want it to sit way up here. And if we were to count our thoracic ribs, or vertebral bodies, we would get down to about T6. That's where we want it. We want it between T6 and T9. The reason we want it so high is that we want the catheter to be beyond these very important arteries that come off of the aorta. The celiac trunk and the superior mesenteric artery are the major blood supply to the intestines, and the renal arteries, of course, go to the kidneys. So we don't want a catheter sitting around these arteries. We want it well above. And that would be between T6 and T9 on the left side of the body. That's why when you look at an umbilical artery, you can see that it goes down like this and then back up. It's because it needs to feed into these structures. The umbilical venous catheter doesn't have that long of a distance to go. It goes into the umbilical vein, it travels up the umbilical vein, and it goes through this structure right here called the ductus venosus. It then enters into the inferior vena cava and sits right at the level of the right atrium and the inferior vena cava. If this structure is closed, the catheter will go to the left, to the portal vein, or to the right hepatic vein, or it'll make a little curve and a turn, goes to the left side of the body, where it goes into the left hepatic vein. So we need this structure, the ductus venosus, to be open in order for the umbilical vein to go into the correct position. Remember that the vein, the inferior vena cava, is on the body's right side. So you'll see that the umbilical venous catheter will be on the right side of the body, and the umbilical arterial catheter will be on the left side of the body. So here we have an X-ray. Using our technique, we see that it's pretty well inflated. 1, 2, 3, 4, 5, 6, 7, 8. Yes, we're going to look at our structures. Let's see, the ET tube is here. We can see that carina is right here, and that ET tube is sitting right at the level of the carina. So we'll be telling respiratory to pull back that ET tube. Our UBC is sitting right here. So when we count 1, 2, 3, 4, 5, 6, 7, 8, we see that the UVC is right at T8. It's on the right side of the body. Over here, 1, 2, 3, 4, 5, 6, 7. UAC is about at T7, putting it between T6 and T9. It's in good position. You can see it dips down, like we talked about before, into the internal iliac artery, into the iliac artery, into the aorta, and up. Our OG is here. This might be in a little far. Here's the stomach bubble. We could pull it back a little bit. Baby's well inflated, down to T8. The leads are off the chest, giving us a very clear picture of the baby. The vertebral bodies are straight. The ribs are straight on both sides. Baby is being held. His head is in the midline. This is an excellent X-ray. So now we have a way of looking at X-rays, determining if it's a good X-ray, finding out how far the baby is inflated, knowing where our carina is, knowing where the clavicles are, figuring out where our structures are, such as a UVC, UAC, and our ET tube, making sure our gastric tube is in the correct place. But now we're ready to move on and look at pathologic conditions. But before we do that, we're going to look at this X-ray of a UVC that's in the improper position. You can see that this UVC was placed, and it didn't go there. The ductus venosus was closed. So here it's gone to the left, placing it in the portal vein or the hepatic vein. You can also see these little tiny bubbles right here. So there must have been a couple of air bubbles in the umbilical venous catheter when it was flushed. And it put air bubbles into the portal venous branches. Those will resolve on their own. The body will absorb those. Also note that this umbilical artery is very low. Some NICUs use what's called a low-lying arterial line, and they place it around lumbar vertebral body 3. You can see that this is the last rib, so that's T12. The lumbar vertebral bodies are next, so here is L1, L2, L3, L4. So this catheter is around L3. When you have a low-lying umbilical catheter, you want it between L3 and L4. You want it below those structures we talked about before, the renal artery and the mesenteric artery. So this would be called a low-lying umbilical artery catheter.